Good afternoon, everyone. My name is Carol Buller, and I am just feeling very fortunate to have this time to spend with you. I want to tell you a little bit about myself to give you a little background. First of all, I've been part of the TPOPP team since about 2009, and it's great to be at this point where we can start having these Zoom conversations. 2009, Zoom was not even there. I've been a nurse practitioner and a gerontological nurse practitioner for many years. And I've been in a number of different settings. As we go through this, in years past, I helped start some adult day treatment centers. I've done home health care for many years. I've been a gerontological nurse practitioner in both a primary care setting, as well as long-term care, assisted living, palliative care. I also helped many of my patients in the last months, the last years of their life, to have meaningful deaths too. In the geriatric practice setting, when I did leave that particular practice setting this last June, I'd been there about 18 or 19 years. And I would find myself saying to some of my patients who are in their 90s, you know, I knew you when you were 80. And that was a pretty amazing distinction to make too. So now I actually am at faculty at KU School of Nursing, where I teach in the adult gero nurse practitioner program. My passions are working with older adults, but also looking at advanced care planning and having serious illness conversations. And I've spent probably the last 20 or 30 years trying to refine this conversation too. When I initially thought about talking with you, I thought about sharing some of my uncomfortable situations, because there's many times when I did not have the most smooth conversations with people, and I'm still in the process of learning. I just started a new practice, and it's in a very diverse setting. I take care of about 50% of my patients are Latino. I have African American, I have non-English speakers, and I have refugees. And this is a new way to talk about conversations with older adults too. So I'm in the process of learning once again. So this is what we're going to do in this session. We're going to talk a little bit about who our people are in the long-term care, the community setting. We'll look at strategies to engage in advanced care planning conversations. We'll look at different communication opportunities. I do want to talk about conducting family meetings, and then I want to summarize some appropriate documentation of conversations. So long-term care services are really not just that time only. Long-term care services can be provided by home health, by hospice care, by formal and informal caregivers. They can be provided within organizations such as long-term care communities or continuing care or retirement communities, and in residential care, in assisted living, in Home Plus programs, and in group homes. So I'm going to talk in terms of being in these situations when you're engaging in conversations. So these are our people, and as you can see in the adult day center, service center, most of those individuals are in their 70s to 80s. But as you get into hospice, nursing homes, and residential care, you see many, many more people who are 85 and older, the oldest old. And I always tell in my patient population that when they come in and they're 65, you say, you are my young older adults. You don't get old until you're about 75 to 85 or so. You really don't become the oldest old until you're above 90. And these persons in these community populations and residential settings are very often individuals who have had recent hospitalizations. They have multiple diagnoses. They may take more than 5 medications, and clearly if you're working with older adults, you'll see that they may be taking 10 and up to 20 different medications. Very often our people have mobility issues. They have Alzheimer's disease and dementia, because we know by the time that you turn 85, 1 in 3 persons will have dementia. They are advanced age, and the oldest, the fastest growing segment of the senior population. And if you're an older adult, you're living with chronic illness, you have the greatest risk for serious illness, you have a high risk of losing your decision-making capacity because of either illness or because of a chronic cognitive issue, and you have increased vulnerability when encountering that medical system. And this is particularly true in transitions, transitioning from one part of the medical system to the other, coming from hospital to post-acute rehab, going to long-term care, going to home health. Those transitions can be very, very difficult times for our older adults. And older adults die of chronic conditions that started in their 50s, their 60s, their 70s, including heart disease and cancer, but Alzheimer's disease, kidney disease, hypertension, and Parkinson's disease. But you know, these are our people, and these are the people that I choose to take care of. These are the people that tell me the most amazing stories. The woman who told me the story about hearing and seeing the fireworks at the turn of the century in 1900 when she was 5, and in 2000 hearing the fireworks and seeing the new century in 2000. These are the people who are survivors. They're the skinny World War I private, World War II private that went off, who can now tell me about these amazing stories from his experience in World War II. These are the curmudgeons, or they're the persons who will always give you a hug when you see them. They really are our people. But I also know that these people are influenced by a number of major legislative influences, and I just have to remind us of that. You know, the people that I see are on Medicare and Medicaid. They were, the advanced directives has been informed by the Patient Self-Determination Act. And we protect their autonomy a lot more now than we did back in 1970 and 1980. And now the Patient Protection and Affordable Care Act has allowed me to actually bill for advanced care planning conversations. You just saw this slide before, and as you can see, when we are caring in these community settings for older adults, they may come in with chronic illnesses, but these chronic illnesses may not be providing serious illness at the time. And that chronic illness may progress to serious illness. There may be crises in decline, and there will be crises in decline. And then the reality of it is that these older adults that we're taking care of at some point in time will transition to the end of their life and they will die. That is truly the reality. And so when we see them at the time of the serious illness and then progressing to end of life. But you know, oftentimes we see these individuals who have not identified their proxy. They have not discussed they had a conversation about care preferences. They have just been living their lives and not given much thought to what are some of the pretty serious conversations or decisions that they're going to have to make in the future. And I thought it was interesting in reading this recent research study with the National Health and Aging Trend Study, where they asked the question, have you talked with anyone about the type of medical treatment you would want or not want if you became serious ill in the future? Now remember, this was a study that was looking at just older adults, and 61% of these individuals said, yes, they had talked to someone about the type of medical treatment they would want. But what about the other 49%? They found in the study that factors that were associated with end-of-life discussions were being younger, having more education, and having multiple chronic conditions, and that the African American race or that ethnic group was associated with lower odds of reporting a discussion. One of my colleagues at the School of Nursing at KU published a research study where they actually looked at persons in long-term care. They looked at the staff, and they asked them who was responsible for talking about death and dying, who was responsible for talking about certain things with the residents in long-term care. The direct care staff clearly said the professional healthcare team should talk with the patient, talk with the family about death and dying, and that professional healthcare team might include the nurse, the social worker, the physician, the nurse practitioner. And that talking about DNR orders was part of the intake and the assessment process, and nursing or social work needs to own that. Communication about hospice was triggered by the physician or maybe the family, but not necessarily by the staff. But there were still times for conversations that were had during care plan meetings. So we talk a lot about person-centered care, both in home health, in hospice, in long-term care. And having the conversation is more about having that relationship with that person, with giving that person time to express their needs and wishes, rather than going through and having them make all these decisions all at once. So person-centered care is achieved through understanding a person's preferences and how the person wants to live their life, and also how they want to influence their own death. And I believe that the community settings that I'm talking about offer time to develop the relationships. That's one of the blessings of working in a community setting, like a long-term care or assisted living, is that you generally have time to have those conversations. And those conversations should be had before you have the crisis and before you have the acute experience too in the hospital. But I know that there's a lot of things to do when you admit a person to your hospice, to your home health, to any type of organization or facility. There's a lot of things to do. In long-term care, there's many checklists and there's many preference things that you need to do. And I experienced this for myself with both of my parents and my father-in-law entered a long-term care facility, a very fine long-term care facility. But one of the things that they had in their mission packet giving to the family members was a checklist of preferences. And this was mixed in with all the other things that you had to sign and complete for admission. My brother-in-law called me up and said, I really don't know what to do with this checklist. I don't understand what this means. And so I had the opportunity to actually bring the whole family together, and we looked at that checklist. And individuals were supposed to check their preference for CPR, for going to the hospital, for having a G-tube, for having dialysis, for having a variety of medical interventions at certain points in their life. I don't think most of the people or family members would know what to do with that. And I think it was unfair to ask people to make medical decisions when they didn't have anyone to vet those decisions or even to talk about that. It was a blessing for me because I got to spend time with that family that had not talked about my father-in-law's preferences and wishes, so we were able to do that. And the checklist, while we didn't complete it, it really was a thing that we could use to have that conversation. In the case of my father, we had had those conversations well in advance, and so I knew exactly what his preferences were, and I am grateful for that. Again, the timing of all that paperwork that you have to complete when you admit someone to a long-term care, a skilled nursing facility, post-acute care, home health. There's the diagnosis that you have to find, the allergies, make sure they have a diet, the medications, and by the way, what about the DNR? I had a daughter who I talked with shortly after her mother was admitted to a long-term care facility. And I had noticed when I was going to visit the mother, who had been my patient in the office, that she had listed that she wanted a full code. There was no DNR signed. I thought this was interesting because we had had a number of conversations. It was very clear what her preferences and wishes were for her care at end of life, and that would have included do not resuscitate as a directive. And I asked the daughter a little bit about that, and she said, well, you know, it was late in the evening when we went, and it was busy, and there was all this paperwork, and the nurse was pretty intent on getting the paperwork done, and she kept asking if mom wanted a DNR, and I just said, a DN what? I didn't know exactly what she was saying. And I knew actually what she was asking, but I didn't want to make that decision at that time. And so the paperwork was not signed for a DNR directive, and no one really revisited that again. And no one thought to ask the woman who was perfectly competent to answer those questions about what her wishes and preferences would be. So that just lists a couple of those barriers of having those conversations, and time pressure being one of the big ones. But some of the other barriers that we have when that have been listed, identified as barriers to conversations, include that personal barrier, the lack of experience or education, the fear of saying the wrong thing, the fear of emotions. The fear of legal ramifications. What if I see something and I'm sued? Another barrier can be when decision makers are really not available, or they're unwilling to come in or unwilling to talk, or the person that you're trying to have a conversation with is not able to communicate. And again, thinking that that conversation really begins to the doctor, it belongs to someone else, it belongs to the nurse practitioner, the doctor, the social worker do it, someone else will do it. It's not something that I have time or need to do. But we also know that some of the things that facilitate conversations are experience, just having the time to sit down and have the questions. For me, it wasn't education, it was learning on the job. And now I look for ways to educate my students, but really having that conversation was, I learned by talking with people. Another facilitator, though, to have conversations is to have interprofessional team involvement and support. When social worker, physician, nurse practitioner, nurse, chaplain can all be involved and support that conversation. I found that one of the biggest facilitators for me was to have a trusting relationship with patients. And also, when there is a terminal diagnosis that the person is aware of, or when they're on palliative care, because it opens the possibilities to have those conversations. And really to facilitate them, also to have them in person. I have had conversations on the phone, and it's always difficult. It's like having a conversation with you and not being able to see your face, not being able to get that feedback, not being able to get the nonverbal conversations. So discussions in person are cherished. When you work in places like the community, long-term care, assisted living, there are conditioned conversation sparks. And I used to call it triggers, but I'm really trying to get away from gun language. So I'll call them sparks. And some of those sparks could be a recent hospitalization or a readmission to your organization or to your community. It might be a decline that you're seeing in the person's functional level, their ability to do ADLs. These times, a conversation spark might be that progressive weight loss. Or for me, it's when I start hearing the staff in an organization start whispering about, is it time for this person to have hospice? And they're starting to send me SBARs about hospice for the individual. Definitely, those are the times to have a conversation with the person, the family, and the team too. And then there are those daily conversation sparks. There's all the time those behind the scene discussions, expressions of thoughts and concerns and values that you hear every day. You know, it's that person who says, I am not sure I'm going to make it home. Or it's that person who said, this isn't where I expected to end up. Or that individual who says, I don't want to be kept alive if I don't have any quality of life. In each of those times, if you can take the moment to say, tell me more about that. Tell me what you're feeling or what you're thinking. Tell me what you mean by you don't want to be kept alive if you don't have quality of life. Those are perfect opportunities to ask the question. And those type of questions and listening time are ones that inform those decisions for the future. And then there are those transition opportunities. Discharge planning provides the unique transition opportunity to talk about what happens when. What's going to happen if you have a serious illness or if this heart failure flares up again? What are your wishes about going to the hospital and such? Care planning meetings in long-term care, in assisted living, or wherever you have care planning meetings in hospice, home health, are great transition opportunities to talk about advanced care planning and to talk about persons' wishes and preferences. And then family meetings, and we'll talk about that further in setting up that family meeting. So I worked in a primary care geriatric clinic for many years, and I had the opportunity to see many older adults in a variety of ages. Remember, I said anywhere from 60 to 106. And so I had many opportunities to do advanced care planning. First of all, I had the Medicare wellness visit, which has a question or a specification where you ask the person, do you have an advance directive? And you ask them about their wishes and preferences, and you ask them about if they have appointed someone as their durable power of attorney for healthcare. I've also had the opportunity when people are facing a new diagnosis, and this might be after they come home from a hospital follow-up visit, or it might be during a transitional care visit where they've been discharged and we're looking at transitional care. And then now it's in that advanced care planning discussion visit. My good friend and nurse colleague used to tell me that I could make an advanced care planning visit out of any visit. And I would say that, you know, when the opportunity presents, I use it. And so if this person came in with something and goes out with in a do not resuscitate, outside the hospital do not resuscitate form because that's important to them, that's important to me as well. I want to talk about some communication behaviors that are genuinely valued by patients and families. And this makes up for not always having the words. And this is one of the ways to be developing trust with our patients, with our families, with our residents. And that's actually being present. And it doesn't always mean speaking, but sometimes it means just being there and holding their hands. It also means being in the moment, not checking your phone, not looking for the next light, not looking for the next thing that you're going to be doing. And it's knowing and being comfortable with yourself, being able to sit down for 5 minutes in this person's room and ask them about themselves. And it's also knowing that other person and connecting in ways. These communication behaviors also include affirming and valuing their decisions and their choices that they make, and acknowledging vulnerability, saying to them, you know, it really must be hard to be in that situation, or that must have been scary to be in the hospital and have all those things happen. It's utilizing that intuition that has been built into us, and it's empathizing and willing to be vulnerable as well. Willing to say that you made a mistake about something, willing to apologize for things, willing to tell people that you don't have all the answers, and providing that serenity and silence. So now we've talked about all this stuff. Now we're going to talk a little bit about beginning the conversation. And I want to weave through that these conversations are not always formal. They can be very informal, and they can be accumulation of many conversations that you've had with the individual. But first of all, normalizing it. You may say that I would like to talk about some possible healthcare decisions in the future. I would like to talk about what you think about your diagnosis. You know, I bring this up with all of my patients. And that is certainly a way to normalize it within that Medicare wellness exam, and it's a way to normalize this when you see people in other venues too. Oftentimes I will respond to a recent event, and I will ask the question, I'd like to know your feelings about going to the emergency room and being admitted to ICU. What was that like? What if that happened again? Would you do that again? Or what would you do differently? And then it's always important to ask permission. Is it okay if we talk now about some of the decisions that you'll have to make in the future? And sometimes it is okay, but sometimes people will say, you know, I want to wait on that. Or sometimes family members say that too. And then we wait. We say, but you make it time to come back and talk about it again. If you have the luxury to do that, which oftentimes we have in these community settings, you can say, yes, that sounds great. How about if I come back next Tuesday when I'm here on the floor? I often ask about advanced directives. Well, we have to, because that was part of what we're required to do by law. But this is some of the things that happens when you ask about advanced directives. Sometimes they say, I did that a long time ago. It's fine. The lawyer has it. It's in my safe deposit box. Or my daughter knows what I want. Or I've done that all. It's all complete. Then I have to take a step back and say, tell me what you have written down on your advanced directive. Because once again, when we're talking about things like directives for do not resuscitate or directives for hospitalization and such, many people believe that that advance directive is a physician order. And if they put that on the directive, then people should follow that. And that's not always what happens. It's a directive. So what I have found out is that what sometimes people believe, is that they have all their funeral preparations made, and they have, their daughter knows what dress to put them in, and they know what type of casket they've picked out. And it has nothing to do with what happens before they actually die. And so we have to go back a ways, and we have to talk a little bit more about what happens when that serious illness comes. Oh, so what about that serious illness? If you had a serious illness and wouldn't be able to talk or be able to tell us what you would want, who would you want to speak for you? And oftentimes people who have completed a durable power of attorney for healthcare will certainly have that in mind. Well, my daughter will do that for me. And then I often move to the next conversation, and I say, when was the last time that you talked with that person about your wishes, about what you would want them to say on your behalf if you were in that situation? And very often, it really was the last time they may have talked about that was when they completed that form, or maybe that person hasn't even, doesn't even know that they're the agent for that. And I encourage them to talk with that person about what their wishes would be. And sometimes they say, use me as an excuse. Say you went to the medical office and they talked about this, and they said I needed to talk with you, my daughter, about that. But I also give them a chance. I say, would you like the chance to talk together? And then if that's the case, then I can schedule an advanced care planning conversation in my office, and we can bring the family members in, and we can talk with that individual and talk together about having a serious illness conversation. The other thing that I frequently ask about is quality of life. And I usually preface this on pretty much anyone that I meet as a new patient, but I also talk about this with individuals through their lifetime, because I want to know what's important to them, and I want to know how I can help them identify what's important now and what's going to be important in the future. And it's a good question, because my quality of life is not your quality of life. What I think is quality of life for myself is not the same thing as quality of life that my mother thinks of what is for her. So to get at these questions, I often ask, what's most important to you now? Now, I will say that I get a lot of blank faces, because people don't usually get asked that question. And so I may ask about that. I may have another question that I say, well, what activities or experiences are making your day meaningful? And I find that interesting, because when you're talking with someone in a long-term care facility where their life is now shrunken to about a small space, and they no longer leave that place, it's interesting to me to see what they find meaningful. Some people will tell me it's food. Some people, oftentimes they talk about families. Sometimes it's the care that's provided. But even in those activities, you know what quality of life is. And I'm getting a drop-down box here. I'm not sure if that's questions or if it's anything else. So we'll stop after this, and then I'll go down to that again. And then sometimes I will say, what helps you when you face serious challenges in your life? Because, you know, these older adults, pardon? Don't worry about it. Okay. So these older adults have had many opportunities to face serious challenges. What worked in their lives before? And I might ask, do you have things you're looking forward to? And then I ask, do you find yourself thinking a lot about death? Because let's face it, you know, they are thinking about death. They are seeing their roommates die if they're in long-term care. Their friends have died. You can't help but think about death. That, I believe, is a life stage they have to go through. But when we start talking about this, I use phrases like, tell me about this, tell me more, to help encourage them to talk about this. So I had an interesting experience. I asked a gentleman who I was often wondering about his quality of life, what was most important to him now. He had been an engineer, he had advanced Parkinson's disease, he had many, many mobility challenges, he had difficulty speaking, but he told me that the most important thing that he found during the day was when he could, my battery's getting low, was when he could take an engine and take that engine completely apart and have all parts laid out in his brain, and then one by one he would put those parts back together in his engine, and he would put that engine all back together again. And then the next day he'd look at something different, and he would do all these mental challenges where he was taking things apart and putting back together again. And he looked at me and he told me that, I'm sorry, we're having some technical issues here, but we're trying to get it back together again. Anyways, he looked at me and he very clearly said, when I can no longer do that, then I do not want to keep living. Well, this individual started having some small strokes, and one day he had the big stroke, and he ended up being sent to the emergency room, and fortunately they made a decision not to do anything further. And that was so important, because at the point where he was having the strokes, where he had the big stroke, he would not have been able to take apart those engines and put them back together again. So that's where asking those questions and finding out about quality of life was so important. And when I talked to his son after that was over, we both agreed that that was one of the best decisions that the son was able to make, was to allow him to have that comfortable, quiet death. I'm sure you have many stories yourself and patients and persons that you've dealt with as well. So now let's talk a little bit about patient and family meetings, or resident and family meetings. And I am assuming that hopefully that many of the persons who are listening are hopefully social workers, nurses, who are involved in doing some of these family meetings together. I think it's really important to pre-plan before you call a family meeting, and to meet with the other clinicians so that you can assure that there's going to be a consistency of message. So finding out from them what they're seeing before you actually call the family meeting and go in together. You know, sometimes I find out from nurses who had completed a family meeting that there were some pretty significant issues that were coming, and they needed some direction from a healthcare provider in making some of those decisions. And so with my nursing staff, I told them that I was really available to come to those family meetings so that we could clarify some of the medical issues that were coming up, so that we could have consistent messages too. When you do decide to have a meeting, it's important to clarify the goals of the meeting with both the patient, the family, and staff. If it's just an annual care plan meeting, you can clarify those goals. We're going to be talking about your care here, but we also want to talk about future goals and preferences for future. If it's related to talking about serious illness conversations, I think it's important to say, we want to talk about what's going on with your mom, with some of the decisions that are going to be that we're going to need to make in the future. And then decide on and invite those essential people. I find that it's better not to have too many people, outside people in the room. Invite the family members, the significant others, the persons that are important. But we don't need to have all the staff in the team there unless they're going to be contributing to that family meeting. And there are different family meetings. Granted, there's the rehab meeting where you talk about the goals for rehab and such. But when we're talking about some serious illness conversations, we're talking about next steps with palliative care, with making decisions about future treatments. I think it's important to not overwhelm people. As John mentioned before, and as you can well imagine, arrange for that appropriate setting and privacy. Book a room. Try to find some place where you can have enough chairs to get everyone in there. And then make introductions in the relationship to the patient. That's so important to have that. I find that when I have the person or the patient there, they're the person who is sitting closest to me, because they really are the person that is in center and is in charge of this conversation too. And many times, some of my residents who even have cognitive issues will be there. They may not understand everything that's going on, but they still are the center of this conversation. Before we begin, we want to review the goals of the meeting. I try and meet with the staff beforehand because I want to know what their goals are. I know what my goals are. With the family, they may have some specific goals too that they want to know about. So we need to review the goals of the meeting, and sometimes we can't meet all those goals in one meeting. And then we want to elicit the patient or family understanding of the care to date. A good way to say this is, how do you think mom's been doing? Or if it's the person, how do you think you've been doing? What do you know about your diagnosis? What did you learn from your last visit to the oncologist? And then review some of the current medical conditions. And if you're in long-term care settings, some of those that review might be related to falls, it might be related to weight loss, to cognition, it might be related to functional status. It may be related to the diagnosis as well. And then we ask questions and we attend to questions. We ask, what questions do you have? What questions do family members have? And what questions do the staff have? And then review the options for care. What things can we do here? What things are available outside of our unit or outside of our community? And make sure that those options for care are realistic too. And make sure that when you're providing options that you can actually provide those. And if you can't, try and find someone else who could do that, if that's possible, or to review how realistic those options are. Then it's important to elicit a response from the patient and family, or from the family, based on what the patient would choose. So many times you're in a situation where the person no longer is able to communicate or make decisions for the future, and so the family, being the agent, is the persons who are responsible for this decision. And I always try and preface it as, if your mom could be with us in this meeting, what would she choose? Or what do you think her response would be to this? And then finally, after you're with that, you want to review the plan. Talk about the decisions that you've made. Talk about the conversations that you've had. And then plan for a follow-up meeting too, because sometimes decisions can't be made in one meeting. Sometimes you have to say, we need to follow up in about 2 days, or I'll call you in 2 days and we'll talk about this a little further. Or if it's the individual in a long-term care facility, I'll plan to stop by at the end of the week and we'll talk about this further. The other important thing to talk about, especially when you're in situations where you're needing to make some serious decisions or talking about palliative care, or maybe redirecting the course of care, is to ensure that you are going to try and provide the best care possible for a family member. I often talk about it as aggressive comfort care instead of aggressive treatments. We're really going to try and focus on the things that we can do to make you comfortable, and the things that we can make you happy during your day. And then finally, document the meeting. Documentation is so important. Who attended, identify what was discussed and what that plan was. These family meetings are so important, and sometimes you can really see how important they are. And so another story that I want to share with you is a woman that I took care of, had several visits with her in the office with her daughters and herself. She had had a stroke. She had some limited mobility issues, also had some conversational issues, but we talked about some of her wishes and preferences for care in the future. And we did this over a couple of meetings too. As what happened, she ended up in the hospital and she had a severe stroke. and they were discussing palliative care, and the family was asked to make some decisions on her behalf. And she actually was able to die comfortably in the hospital. I got the discharge summary, and I also got the palliative care report. And in the palliative care report, the palliative care physician indicated that when they had a goals of care discussion, that the family was very clear that they had talked with me about these decisions for the future in our office, and these were the wishes of the person, of their mother at the time. So that was very gratifying to know that, number one, the family felt bold enough to say that they had a good plan in mind, and that the palliative care physician recognized that in her transitional care as well. Next story. Okay, so here's some other things about talking things that come up in my practice. So talking about CPR, that old D and what. That's something that is so common for us to talk about, and it's very common and people know about CPR. Many of them took CPR training. And so when you talk about asking about CPR, you have to normalize it. And so what I often say is, you know, when you go into the hospital or you come into an organization like this or a community like this, you're often asked about your preferences for having CPR, cardiopulmonary resuscitation. And I ask them if they have any preferences about CPR or what they know about CPR. And they usually tell me a little bit about what they know about CPR. And oftentimes they'll tell me at that point, I don't want that. And I've already signed this order for DNR. That's already on my chart. But oftentimes they will say that they tell me about CPR, and I will ask them, what would you hope for if you had CPR? And oftentimes the response is, you know, I hope that I would get better, that I would recover and I would get better. And then that provides you the avenue with providing a little bit of information on CPR as a medical treatment. So I'm always full of stories. I was in a meeting, and this was a care plan meeting, and I was just finishing up something in the room, and they were starting to review some of the orders and things with an individual in the room. And she had some mild dementia, but she was still able to make quite a few decisions. And the person who was running the meeting asked her, she said to her, so you still want to be DNR, right? And the woman looked at her and she said, yes. And I thought, wait a minute. I bet this person doesn't even know what that means. And so I couldn't help myself. And I asked her, do you know what DNR means? And she said, no. And I said, well, let's talk a little bit about it. So we talked about CPR, and we talked about CPR as a medical treatment too. Okay, one other thing that I often say is when they say that they hope to get better, I often will have to say, well, you know, CPR is not as successful as we think it is. And certainly it's not as successful in older people who have chronic conditions, who have heart disease and such. If you had CPR, you're likely going to have some damage to your ribs. You're likely going to need to spend some time in the intensive care unit, and you'll need continued treatment after you come out, if you even survive that. So that's one of the ways that we talk about that. Another thing that I hear a lot is in talking with family members, and they're talking about making decisions for their family, but then they always preface this with, I don't mean for this to sound bad, but you know, I just want her to be comfortable. I don't really want her to have things to prolong her life. I just want her to be comfortable. And they'll often say, what is this going to look like, particularly in situations with dementia? And it's perfectly fine to say, would you like me to talk about what my experience has been with individuals who have advanced dementia and what that looks like? Because that allows them to have your knowledge and your expertise in what this process looks like, and maybe to be able to get some anticipatory guidance. And then again, I will say, if we're making decisions, what do you think your mother would say if she could see herself? And what would she tell you she would want? And that certainly puts that in for the daughter or the son who's ever making a decision in their mother's perspective. We have talked a little bit about TPOPP, and unfortunately I don't have the form on my paper, but Maria is going to talk about that in our next segment. But here's how I talk about options for treatment. Sometimes I say, well, you know, oftentimes people have different options for treatment, and this is in the terms of long-term care. Many people say that they would like to have treatment in the hospital. They'd want to have an ICU admission if needed. They'd want to have support on a breathing machine. They may want to have dialysis. That's very important for them. There are other people who say that, you know, I would like to treat conditions that would be reversible. I would like IV fluids. I would like pain management, but I really don't want to have a breathing tube, or I don't want to have dialysis. And there are other people who talk about just wanting to have relief from symptoms, want their pain treated, but they don't want to go to the hospital. They don't want to have aggressive treatment, or they don't want to have a lot of medical treatment, particularly outside of this community. And so that helps people identify what are some of the options for treatment. Does it mean that we're going to treat some things, or does it mean that we're going to give the full court press too? And I'll explain things that we can do in the long-term care setting. Sometimes we do IV fluids when it helps make people feel more comfortable. Sometimes we do antibiotics, particularly when it makes them feel more comfortable. So talking about some of those options are important for them. So I'm going to wrap up and leave a little time for questions, first of all. I believe that advanced care planning is pretty person-centered, and it's very relational. It's really that whole part about listening, about information gathering, asking for the patient. It's about information giving. It's very individualized. It's very much about relationship building. And the advanced care planning process is very much about that conversation. And so finally, as we wrap up, I hope that I've given you a few ideas of what you can use in your setting. And I hope that you'll continue learning and reading about having conversations, and having them, because that's one of the best ways to learn to do something is really being vulnerable to have those conversations. I have to give it credit for this picture. This is my father and my mother, their hands intertwined. This is when my father was dying in the last 2 hours of his life, and this is my mother who is giving him support and comfort. So thank you very much for allowing me to be with you, and I'll take any questions that you have. And the good thing is that we're a little bit early, so we'll have time for a break too. Matthew, are you on there too?
I am. Right now we're queue's empty, so if anyone wants to drop a question in there, we'll let you know. Otherwise, we can just take a break for a little bit. Maybe take a break and come back and see if there are any questions.
Okay, thank you, Matthew.
Uh-huh.